Assalamu alaikum. Thank you for giving me the command to take history and examine the patient. My patient Iman, daughter of Amir Ali, 16 years of age, unmarried, student of class 9, resident of Hijweri town, Faisalabad, presented to us via OPD on 3rd April 2025 with following chief complaints. First, start from erosions on legs bilaterally associated with pain, burning, and difficulty walking for 2 months. She was all right at birth when she started developing multiple tense, clear, fluid-filled blisters starting from feet, gradually spreading to involve ankles, knees, elbows, predominantly the trauma-prone sites. At 2 months of age, there was sparing of abdomen and back of the trunk. The blisters were small initially, gradually increased in size over a period of few days. Some blisters ruptured on their own after a period of few days, whereas others were ruptured by the patient herself, leaving behind erosions that were equal to the size of the blister. The erosion healed after 10 to 15 days with atrophic hypopigmented scars. There was no history of blistering in a specific pattern, generalized erythema, erosions or blistering or tight shiny membrane at birth, hypo or hyperpigmented macules predominantly on the photoexposed sites, photosensitivity. The blisters were not followed by contracture formation. There was no preceding history of urticated plaques on friction. There is history of burning and redness on exposure to sunlight, milia formation. It worsened in summers, improved in winters and on application of the topical steroids and emollients, and off and on oral steroids. There is history of blister formation on scalp, periungual region, followed by non-scarring hair loss and onycholysis, hoarseness of voice, dysuria and constipation, malalignment and loss of teeth, predominantly from the upper jaw. Sweating is normal. No history of chronic non-healing ulcers on any part of the body. Shortness of breath, disuse, atrophy, weakness of any part of body, fits, palpitations, pedal or facial swelling, loose stools or indigestion, heat or cold intolerance, lumps or bumps in the body, associated with drenching night sweats and weight loss. There is history of decreased weight gain and height. There is no preceding history of investigation, skin biopsy, Zack smear, or previous hospital admission. She is normotensive, normoglycemic, no issue of asthma, tuberculosis, hepatitis B, C, or HIV screening, or blood transfusion. She has history of 5 to 6 surgeries for the cleft lip and palate at the age of 1 and 1.5 years. She has a regular menstrual cycle of 28 days with average flow. Her parents are cousins. She has 4 other siblings, but all of them are normal. Although there is history of 5 to 6 affected family members from the maternal side. Her father is laborer by occupation. The disease is having more severe effect on her quality of life, and it has controlled over time according to the patient and her attendant. General physical examination. Her blood pressure is 100 by 60 millimeters of mercury. Pulse was 78 per minute. Regular and rhythm, average volume, with no radial or radiofemoral delay. Respiratory rate was 24 per minute. Pallor positive with bilateral pedal edema till mid-legs. Pitting type. No pallor jaundice or cyanosis. Clubbing. On cutaneous examination, there are multiple tense clear fluid filled bullae on ankle joints, dorsal aspect of the feet, lower 1/3 of the left leg, and right knee joint with negative Nikolsky and Esbo-Hansen signs. There is a single large flaccid pus-filled bulla close to the right ankle joint with overlying yellowish crust. There are multiple freshly healed erosions on the dorsal aspect of the feet, anterior shins, elbows, right ring finger, and forehead along the anterior hairline. There is bilateral symmetrical involvement of the dorsal aspect of the hands and feet, elbows, knees, and extensor aspects of the legs, front and back of abdomen with multiple atrophic hypopigmented scars, giving the skin a wrinkly and shiny appearance. On examination of the nails, are dystrophic, discolored, and rudimentary of both the finger and toenails. However, the nails of little fingers and thumbs bilaterally are normal. There is sparing of the skin of palms and soles with normal dermatoglyphics. The web spaces are normal, and sparing of the axilla and groin. There are a few excoriations on the bridge of the nose and anterior nares. There is mutilation of the upper lip, which is short and has depressed atrophic hyperpigmented scar on philtrum, maceration of the corners of the mouth, hypertrophy of the gums of the lower gingivae and palate with the linear depressed scar on the palate. The voice has a nasal tone. There is sparing of nasal ocular mucosae. I could not examine the genital mucosa because the patient refused. On examination of the scalp, the hair are of normal density and texture with no scarring or atrophy. On systemic examination, her GCS was 15 by 15 with normal tone, power and reflexes. No limitation of the joint movements. Normal vesicular breath with no added sounds. Apex beat was in the left fifth intercostal space in the anterior axillary line. Non-tapping, non-heaving. Audible first and second heart sounds with no added sound. No hepatosplenomegaly. Upper border of the liver was in the right fifth intercostal space. Bowel sounds were audible 1 to 2 times per minute. No abdominal or inguinal lymphadenopathy. On the basis of history and examination, my differential diagnosis are epidermolysis bullosa.